This is Dr. Cortejos with the last part of our discussion on substance-related and addictive disorders. This session, we will be tackling stimulant-related disorders, tobacco-related disorders, other substance use and addictive disorders, as well as gambling disorder, and a short section on internet gaming disorder and internet addiction. This will be our outline. First, we discuss our stimulant-related disorders. The available preparations of amphetamines include dextroamphetamine, methamphetamine, a mixed dextroamphetamine-amphetamine salt, or Adderall, which is used for ADHD patients, methylphenidate, or Ritalin, which is also used for ADHD patients, ephedrine, pseudoephedrine, and phenylpropanolamine. Amphetamines are also known as ice, crystal meth, or speed. These substances are used to increase performance and to induce euphoric feelings. They are usually inhaled, smoked, or injected intravenously, and they are the second most widely used substances next to marijuana. Amphetamines are known to be less addictive compared to cocaine and are rapidly absorbed and have a rapid onset of action as well. They release catecholamines such as dopamine, which are potent for the dopaminergic neurons in the ventral tegmental area, so we recall the reward circuit pathway. Norepinephrine and serotonin are also released. Cocaine is an alkaloid derived from Erythrocylum coca, which is indigenous to South America. It has stimulating effects as well as vasoconstrictive and analgesic effects. It used to be listed in the 1899 Merck Manual because of its apparent or alleged curative effects, and it also used to be an active ingredient in Coca-Cola until 1903. It was classified as a narcotic in 1914. Cocaine is most prevalently used in young adult males, and the disorder for cocaine use is also comorbid with other psychiatric disorders, most particularly major depressive disorder, bipolar II disorder, cyclothymia, varieties of anxiety disorders, and antisocial personality disorder. Typically, stimulant-related disorders may be preceded by anxiety, symptoms of ADHD, and antisocial personality traits, and may be followed by mood disorders and alcohol-related disorders. Genetic influences have higher concordance rates for stimulant dependence. Availability and environmental cues also influence the use of stimulants. The rush and euphoria felt after using stimulants also perpetuate stimulant-related disorders and problems, as well as the production of the sense of alertness, well-being, and decreased need for sleep, as well as decreased hunger. Cocaine is taken via snorting or tooting and can also be ingested orally or taken through IV injection. Cocaine blocks dopamine reuptake by the dopamine transporter, thereby increasing concentration of dopamine in the synaptic cleft. The reuptake of norepinephrine and serotonin are also blocked, and the behavioral effects of cocaine may last for 30 minutes to an hour. The metabolites may be present in blood and urine and can be tested for up to 10 days. and dependence on this substance may develop even after a single use because of its extreme euphoric effects. These are the different categories of stimulant-related disorders. Diagnosing a stimulant use disorder would again entail looking at the 11 criteria as well as the severity specifiers, seeing the emphasis in the decrease in abilities to cope with usual functioning and fulfilling obligations at work, at school, at home, and in other relationships. Physical symptoms would show weight loss and nasal congestion. Other symptoms may be severe insomnia, personality changes, impaired concentration and irritability, and compulsive behaviors. Financial difficulties may also be noted. Intoxication with stimulants may show physically as mydriasis, tachycardia or bradycardia, presence of chills or perspiration, cardiac arrhythmias, changes in blood pressure, movement problems, nausea or vomiting, and neurological problems such as confusion, seizures, or coma. Patients may also exhibit agitation, impaired judgment, irritability, impulsive behaviors and aggression, increased psychomotor activity, and symptoms of mania. Withdrawal from stimulants, on the other hand, or a crash, is characterized by anxiety, tremulousness, dysphoria, lethargy or fatigue, nightmares, headaches, muscle cramps, and insatiable hunger. The symptoms may peak in 2 to 4 days during withdrawal and may resolve in 1 week. The depression may be very severe, driving the patient into suicidal behaviors. The craving for cocaine may be very intense, and self-medication may be done by the patient using alcohol, sedatives, hypnotics, or anti-anxiety agents. In stimulant intoxication delirium, we have the symptoms of delirium such as fluctuating attention and disorientation, as well as the symptoms of stimulant intoxication. The symptoms of this disorder may be exacerbated or caused by sleep deprivation, use of other substances aside from the stimulants, as well as a pre-existing brain damage. Stimulant-induced psychotic disorder characterized by paranoid delusions and hallucinations, as well as formication, may be most common with those who use IV stimulants and crack cocaine. Stimulants may also induce symptoms of mania or mixed mood features, as well as depressive mood when the patient is in withdrawal. Stimulants may also induce panic disorder and phobic disorder symptoms, as well as a time-limited stereotype behaviors or rituals after taking high doses. Stimulants, which are often misused to enhance sexual experiences, may be associated with erectile disorder with high doses and long-term use. Intoxication with stimulants may cause sleep deprivation and insomnia, and upon withdrawal may cause hypersomnolence and nightmares. Other adverse effects of amphetamines include the possible transmission of HIV and/or hepatitis, as well as cardiac, metabolic, and neurologic symptoms. The use of IV cocaine can also transmit HIV, and it also has cardiac, metabolic, and neurologic symptoms. Notable as well is the nasal congestion and perforation of the nasal septal with use of cocaine that is snorted, as well as the damage in bronchial passages and lungs. Other stimulants with similar effects include MDMA, otherwise known as ecstasy, cat, and club drugs, which are usually a combination of different stimulants and other classes of drugs. Management for stimulant-related disorders may involve having the patient admitted to see them in the inpatient setting, multiple therapeutic methods, which include individual, family, or group therapies, medications such as antipsychotics or anxiolytics, which are used short-term to abate the symptomatic changes in the patient and to manage underlying comorbidities, therapy for comorbid personality disorders, and monitoring using frequent urine testing or blood testing. Now moving on to tobacco-related disorders. Tobacco-related disorders are among the most prevalent, deadly, and costly in our patients. They usually do not cause behavioral problems, thus patients do not typically seek treatment or are referred for management. However, there is a growing recognition that most patients with psychiatric disorders smoke or have died from tobacco dependence. Findings have shown that there are around 3 billion smokers worldwide, and they smoke 6 trillion cigarettes a year. It has also been found that in the US, tobacco-related disorders or smoking itself is very prevalent in psychiatric outpatients, in patients with bipolar I disorder, patients with schizophrenia, and patients with other substance use problems. Patients who are depressed or who have major depressive disorder as well as anxiety disorders have been found to be less successful in quitting their smoking. In the Philippines, it has been found that around 28% of the population aged 15 years old and older smoke cigarettes or tobacco, and that more men use the cigarettes than women. Men smoke an average of around 11.3 sticks daily, and on the other hand, women smoke an average of 7 sticks per day. Nicotine, the active substance in cigarettes, is an agonist at the nicotinic subtype of acetylcholine receptors. 25% of the inhaled nicotine reaches the bloodstream and the brain within 15 seconds, and the half-life of this substance is 2 hours. Nicotine activates the dopaminergic pathway, increasing concentrations as well of circulating norepinephrine and epinephrine, increasing vasopressin, beta-endorphin, adrenocorticotropic hormone, and cortisol. These are the categories of tobacco-related disorders. Tobacco use disorder is characterized by craving, persistent and recurrent use, as well as tolerance and withdrawal with tobacco. It also involves multiple trials or multiple attempts of quitting using the substance. Patients with withdrawal from tobacco may experience the following symptoms within 2 hours of smoking the last cigarette, and these symptoms may peak in 24 to 48 hours and may last for weeks or months. The stimulatory effects of nicotine involves improvement of attention, reaction time, problem solving and learning, as well as mood being lifted and tension being decreased. However, nicotine toxicity has been reported with a 60 milligram dose being seen as fatal. Nicotine may also affect pregnancy and pregnant women as well as their babies with low birth weight and persistent pulmonary hypertension. Part of the management for tobacco-related disorders is the use of nicotine replacement therapies, which may reduce withdrawal from the substance. There is a maintenance period of around 6 to 12 weeks and a gradual reduction period of another 6 to 12 weeks. Nicotine gum and nicotine lozenges are available over the counter. Nicotine gum releases nicotine via chewing and buccal absorption, and nicotine lozenges are useful for those who smoke immediately upon awakening and are seen to have the highest level of the substance among the nicotine replacement products. They are available in different dosages depending on the user's frequency or amount of cigarettes being smoked per day. Nicotine patches can be bought over the counter as well and are administered every morning. Nicotine nasal spray and nicotine inhaler can be bought with prescription. Bupropion, which is an antidepressant with dopaminergic and adrenergic actions, is used as well for tobacco-related disorders. Clonidine is also used to help abate withdrawal symptoms. Also part of the management for tobacco-related disorders is behavior modification, which involves firstly asking the patient about their history of tobacco use or cigarette use, as well as their attempts at stopping using the substance. We also assess how ready they are to quit the substance and to assist them in methods of quitting. We also arrange frequent follow-ups to monitor their progress. A national smoking cessation program has also been mandated by the Tobacco Regulations Act, which orders the DOH to set up withdrawal clinics. Other substance use disorders involve anabolic androgenic steroids, which are used by athletes usually to improve their physique and their performance. Gamma hydroxybutyrate, which is a central nervous system depressant with effects through the endogenous opioid system and increases dopamine levels in the brain. Nitrite inhalants, which are used by persons seeking mild euphoria, altered sense of time, feeling of fullness in the head, and increased sexual feelings. Nitrous oxide or laughing gas, which is a widely available anesthetic agent that is also subject to abuse because of its ability to produce feelings of lightheadedness and of floating, which is experienced as pleasurable. Now we go to a non-substance addictive disorder, which is gambling disorder. This disorder involves persistent and maladaptive gambling, which causes economic problems, as well as impaired functioning or disturbances in personal, social, or occupational relations. The disorder involves a patient's preoccupation with the gambling, the need to gamble with increasing amounts or increasing frequency in order to achieve the desired excitement, repeated unsuccessful efforts to control or to stop gambling, using gambling as a means to escape from problems, gambling to recoup or recover losses, lying to significant others, to family or friends to conceal the extent of gambling, committing illegal acts in order to finance gambling, jeopardizing vocational or personal relationships because of the gambling, and relying on others for money to pay off their debts. Gambling disorder has been found to be comorbid with a family history of substance abuse, in particular alcoholism, as well as depressive disorders. Other comorbid disorders involve depressive disorders and bipolar disorder, alcohol and stimulant abuse, as well as dependence on caffeine and tobacco, ADHD, several personality disorders, in particular narcissistic, antisocial, and borderline personality disorders, as well as disruptive impulse control and conduct disorders. Personal and family histories of persons with gambling disorder may reveal the loss of a parent by death, divorce, or desertion, inappropriate parental discipline, exposure to and availability of gambling activities in the environment, an emphasis in the family on material and financial symbols, and a lack of saving, planning, and budgeting plans within the family. Patients with gambling disorder are said to be characterized by the following phases: the winning phase, which hooks patients; the progressive loss phase, wherein patients structure their lives around the gambling behavior and move from being excellent gamblers to those who take risks, borrow money, miss work, and even lose their jobs. Then comes the desperate phase, with patients gambling with larger and larger amounts of money, not paying debts, becoming involved with illegal activities such as loan sharks, writing bad checks, and embezzling. And lastly, the hopeless stage of accepting that their losses can never be made up or recovered. Patients with gambling disorder may need help with their legal difficulties, family pressures, and other psychiatric complaints. Group therapy, insight-oriented psychotherapy, family therapy, or cognitive behavioral therapy may be useful for these patients. Internet gaming disorder is among the conditions being considered by DSM-5 for further research. According to researchers, these are their proposed symptoms: preoccupation with the gaming behavior, withdrawal symptoms and tolerance, the inability to reduce playing and unsuccessful attempts to quit gaming, giving up other activities and losing interest in other activities, continuing the gaming behavior despite problems at work, at home, or in school, deceiving family members and others about the amount of time they spend on gaming, the use of gaming to relieve negative moods, and jeopardizing relationships and jobs due to gaming. So we have spent 3 sessions discussing the different substance-related and addictive disorders. As with other psychiatric disorders, when we assess our patients with possible substance-related disorders, we always take into consideration the biological, psychological, sociocultural, and even the spiritual underpinnings of these behaviors. What we are able to get from the assessment using these perspectives will help us and inform us with our management as well. We make sure to remember to educate our patients and their families regularly and update them about the patient's progress. And we choose the appropriate medications and we choose the appropriate therapies that are best suited for the situations of our patients. We also have to remember that our patients might become frustrated or their families might become frustrated, or we ourselves as clinicians of these patients might become frustrated if they do not improve right away. But it will be good to remember that recovery is not linear and improvement does not happen overnight. Recovery from substance use disorders takes work and it needs collaboration and active collaboration with the patients, with their families, their friends, their colleagues, and their communities. That ends the series of lectures about substance-related disorders. These are the references that I used for this section. Thank you again for your attention, and I look forward to your insights and your questions during tomorrow's session.